For those of you who have not met yet, Rasu Shrestha, I'm a radiologist by background, trained in informatics and business, and I've been doing this for the last 25, 30 years, really leading health system transformation and innovation and strategy. I'm currently the Chief Innovation and Commercialization Officer for Advocate Health. Advocate Health is really the merger of Atrium Health in the Southeast and Advocate Aurora Healthcare in the Midwest. I joined Advocate when it was still Atrium 6 years ago as the Chief Strategy and Transformation Officer. Some of you remember this, Becky, hi there, in town. At that point, we were a $6 billion annual revenue health system, sizable, right? But the Impact 2025 strategic plan that I had the privilege of authoring and working with the team to build, which really led to some of the things that we'll talk about today, mandated for growth. Right? And it really was about growth, not just for the sake of growth, but growth for the sake of influence and scale, right? And so we've since grown from 6 billion to now 34 billion in the last 5 years or so, and one of the largest health systems in the country. But really excited to talk about this topic of borderless hospitals and culture change and everything else that comes with it. It's a real pleasure to be here.
No, it's actually fantastic because so many of you in the audience will have detailed questions. Before going to Atrium, Rasu was at UPMC, right? Also heading the innovation department. And what he did a lot there was working with people who just started with an idea and going through actual user-centered design, understanding how to code, building the systems, and then launching them within UPMC. So from all the way from UPMC and his prior work, plus the work that goes on at where he's doing it at Advocate now, is details matter. The strategy that you're going to go with, which is, let's start with that strategy, that growth strategy. We know in general, the idea of big box healthcare, where you drive everybody to this big box in the center of town or wherever it might be, is long gone. That's not going to happen as growth anymore. You've pioneered this concept of this borderless hospital. Let's jump into that. The meat of the matter. What does borderless hospital mean to you guys, and what are the challenges of getting to a borderless hospital?
Yeah. So what's really interesting is how innovation really takes shape, and the fact that we've just lived through a pandemic shouldn't be taken lightly. Right? It was March of 2020 when the pandemic, right in the midst of the pandemic, we said, all right, instead of we're looking at New York City at that point, right? And all of how we were reacting as the pandemic was spreading in the United States, and we're contemplating building pop-up hospitals and tents in the Bank of America Stadium in Charlotte. Right? Charlotte is where Atrium Health, now Advocate Health, is headquartered. And at that point, we pivoted and we said, look, we've got this amazing virtual care network that we've set up. We've got this amazing paramedicine program that we've set up. We've got all of these different elements as it relates to mobile medicine and the program around mobile medicine that we've set up. How about if we're able to pivot rapidly and set up this hospital home program? So really within 2 weeks of us coming together as a team, coming up with that idea, right, we're able to launch this hospital home program and target COVID positive and COVID presumptive patients and immediately decompress our ICUs and our EDs. And you know how things were at that point, right? Our hospitals were shut down, $150 million worth of losses every month because, the core bread and butter of the health system, the bricks and mortar facilities, were completely shut down at that point. Second month, 150, the third month, 150 million. Right. So at that point, March of 2020, we turned on our hospital home program, primarily so that we could decompress our ICUs and our ED facilities and treat our COVID positive and COVID patients. Fast forward to today, we're treating over 150 different conditions in the comfort of these patients' homes. And this is now a legit program where, in fact, it is the largest hospital home program in the country. And I remember way back when, 6 years ago, when I was moved to Charlotte from Pittsburgh, and one of the things that we started putting together as part of Impact 2025 was what we call our Connected Care Everywhere strategy, right? And the idea behind that was we said, The next 100-bed hospital really should be these 100 homes in this neighborhood. And then this is the next 100-bed hospital. And this, right? So we're really starting to think creatively in terms of what does connected care everywhere really look like. And today, I'm really proud to say that we this month celebrate 14,000 patients having gone through our hospital home program. Right, the scale and the magnitude of how we've been able to grow this across Advocate Health, and I'll talk about how we're thinking even more broadly beyond that, is just tremendous. So that, in essence, is the way that we're thinking the borderless hospitals. Look, bricks and mortar facilities aren't going to go away. We're human beings. I'm a radiologist. Folks are going to need scans. We're going to need procedures. We might need chemotherapy. Like the bricks and mortar hospitals are not going to go away. The vision that we have is that as we think about borderless hospitals, home is where the health is, right? And if we're able to really address some of the key needs and the wants and desires and really up the experiences for our patients, there's been amazing dialogue this morning already in terms of patients and putting patients in the center of our design and our innovation thesis. What we're about is really broadening that thesis from patient-centered care to person-centered care. And I think that's really important. We still have the patient in the center of our care, but we're now broadening that thesis to more of a person-centered approach to care. And we think that's really critical, right? So borderless hospitals is about moving from patient-centered to person-centered care. It is about moving from bricks and mortar to clicks and mortar, if you can contemplate that. And it is also about really moving from episodic care, which is what healthcare has been about for centuries at a time, right? Well before EMRs, well before Gen AI. It's been about episodic care to now always on pervasive, continuous care, which is what it should be, right? So really excited about the program that we've set up and the embrace that we're starting to see, but it's not been without any struggles.
No, I think a lot of the struggles that you guys have, you've been able to strategically mine those and figure them out and help your executive leadership team weave them through. The challenge that I've seen in other organizations trying to do these borderless and remote first, however you'd like to call it, is that executive leadership teams know how to buy a building, staff it, put people in one place, train for it, etc. But how do you do? COVID forced you to think about this, but unlike most other places, you didn't just say, "Oh, COVID is done, let's go back." You said, "Oh, wait, how do we expand?" So talk about the three things, which is when you are trying to go to the 100-bed hospital in the community, how do you have to think about this from a financial logistics point of view? It's not just about having the money. You have the money, but how do you spend it in those 100 beds in the community rather than here? So that's financial logistics is number one. The second part of them is just the human logistics, like the workforce has to operate now. They've never operated in this environment before, but they have to now. And then the third thing, I think the patients are probably happy, but they're also surprised, right? Like, I didn't realize that if I needed this one piece of thing, that not having a nurse down the hall means that my care might take longer. So you got financial, workforce, and then patient unexpected activities. How does that look in the borderless way?
What's really interesting is we started this because there was a need, right? Our hospital beds were filled, right? The ICUs, the EDs, they were completely filled, and we needed to decompress. And we saw very quickly that beyond COVID and COVID presumptive patients, we're able to grow this to now this over 150 different conditions. From a financial perspective, what's really interesting was what was unexpected out of all of this. Right? We're seeing that compared to the same acuity of cases that we're treating for, in the bricks and mortar facilities, and we still have tons of bricks and mortar facilities, the cost of care is 25% less. So it's actually cheaper for the same conditions for the patients to be treated in the comfort of their home. Right? What's also interesting from that ROI, the financial perspective, is the quality of care is on par, if not better. The outcomes are actually better in the hospital home program than in the bricks and mortar facilities.
But you didn't know that before.
We did not know that.
How did you get them to agree to spend the money in that way,
What we
not
needed,
knowing
like I said, this came as a result of the need
Okay.
that we had, right? We were tracking as an academic learning health system. We were tracking to each of these metrics as we were going live with this program and then growing the program across the board and seeing that the cost of care is dramatically less has been quite uncanny. What's also interesting, however, is this was new. We were pioneering this, and there are other health systems that are also trying, to your point earlier. What's really interesting is that we were not getting reimbursed for this.
Yeah,
Right?
that's what I'm about to bring up.
We're not,
Okay.
right? So from a financial
Yeah.
perspective, the first part of your question, we were actually not getting reimbursed for this. So for us, it was really as a result of knowing that this was the right thing to do at that moment in time, and then starting to see some of these benefits, right, in terms of this being actually financially cheaper for the patient, as well as the experience scores being 10 percentage points higher than bricks and mortar facilities. It's just quite remarkable. So we're not getting reimbursed. What we did start to do, however, was we started to work with some of the payers, and we started to really talk about their members, hence our patients, right, and really figure out the payer and the provider dynamics in all of this. And the payers started to see the rationale around the hospital at home program as well. So it wasn't easy, but Medicare, Medicaid, and we've been trying to push towards the commercial payer population as well. What was also interesting from a financial perspective was the education that we needed to provide to CMS, right? So again, we're in the midst of the pandemic, right? Here we are turning this innovative program on really within 2 weeks of us saying, hey, how about this, right? But the reform as it relates to payment reform was lagging behind. But we did a lot of work working directly with our government affairs team, actually going to DC, educating Congress on the specifics of why this program actually makes sense and why CMS should reimburse in health systems like us. And as a result of that, we're able to get CMS to pass the CMS waiver. So big success there. The CMS waiver ended last year and was extended to March of 2025. So really kicking the can down the road a little bit. We're hoping that it'll get extended by another 5 years. It is a bipartisan supported mandate. And there is a lot of support, a lot of evidence, a lot of data around this as well. So we're hoping that it'll get extended. So from a financial perspective, it's been a struggle, right? Because change is hard. Healthcare is not used to change, right? We like status quo as we've established in the prior dialogue. The second part of your question was really around workforce. And I think it's a really interesting question there. For us, as we started putting this program together, we're bringing together paramedics. We're bringing together EMT folks. We're bringing together nurses and physicians, social workers, right? And the care team that is really around the patient as well, really as one team focused on that patient that we're treating in the comfort of their home. What's really interesting as I've been doing these ride-alongs with our hospital at home teams is talking to the paramedics. Right, as we're going in and rounding on these patients twice a day. So we're doing this, but much like what happens in a
let me understand
brick-and-mortar facility.
They're not nurses going out there. You're just talking. So all of the
paramedics alongside nurses,
alongside,
and virtualists, and care managers and others. So as needed for the care that we're providing to these patients, we're actually rounding on these patients twice a day. And talking to these paramedics, talking to these nurses, what we're starting to see is a level of satisfaction in their jobs that they've never had before.
Nice.
They tell me, Dr. Shrestha, look, we used to drive ambulances back and forth, not knowing, what's going to happen to this patient. And now we have continuity. We're rounding on these patients twice a day for the duration of how long they're admitted into the hospital home program. It could be a 5-day admission, a 4-day admission, a 2-week admission, depending on the severity of the cases and such. But there's continuity. That level of satisfaction that they have is quite tremendous. And then from a job perspective as well, really starting to see how technology is coming to the human element of providing care in the comfort of the home. That's the other element of this as well, right? So in addition to us rounding on these patients twice a day, they are being monitored 24/7, right? So remote patient monitoring, these devices, these sensors, that we're leaving at home. There is round the clock monitoring. There is instant on virtual care that's available to these patients, so that they can talk to any of the care teams at any given point in time. So that level of satisfaction has really gone up through the roof as well. The third part of the question was around the patient. And we think that's really critical, right? So when you look at the home, whether it's for me, you, or anyone in this audience here, the home is a really personal space. It is your private space, and what we're doing is we're inviting now care providers and others into the privacy of your home. And there was a lot of unknown in all of this, right? And as far as the patients are concerned, what they're seeing now, however, is for them to be in the comfort of their homes and not in a sterile environment that is the hospital, right? So imagine this patient that is confused, that is navigating perhaps one of the most challenging times in their lives, right? But also at the same time in a completely different environment in the ICUs, all of the whiz-bangery around them, all the beeps, the sterile environments and all of that, versus them being in the comfort of their home, right? It is a completely different experience altogether. And what we're starting to see right now is that patients are actually asking for this. They are demanding this. We had a AHRQ supported grant funded effort where we actually sat down and interviewed patients. We talked to the patients about the program that we're putting in place. And what they told us, what we found, was that patients were actually asking for this, as opposed to us recommending a hospital home option for patients who would be admitted into an ICU bed. They're coming to us and saying, hey, my mom's elderly, there's dementia, there's confusion. Could we sign her up for this hospital home program? Does she qualify? Right. So there are algorithms and others we have embedded into our EHR that automatically make these recommendations, but patients are coming to us and asking for this just because the satisfaction level is now through the roof.
How far up the acuity do you guys go? And remember, if you guys have questions, raise your hand. We'll pull you in. And it's hard. Rasu is super smart. It's hard to shake him, but let's see. This is a challenge. Ask him a hard question. Finish your thought about how up the chain you go in acuity, and then we'll take this question.
So this is akin to us treating patients in busy ICUs.
Really, all the way up to ICU?
All the way up. Huh. Right. So as far as today,
just for 1 second, does anybody know anywhere else in the country where they're doing ICU health at home?
So we've got patients.
One example. All right, great.
We've got patients with multiple comorbidities that we're treating at home. We're infusing, broad spectrum antibiotics at home. We are even working right now in CAR T cell therapy at home.
Really?
Absolutely.
Wow.
Right? And it's really interesting how, as a result of us being able to really mandate a strict regimen in treating this like a hospital bed, right? So all of the things around CMS and JCO and the quality metrics and all of that, we're mandated to really treat this as a hospital bed, right? So we're admitting a patient to the hospital bed. And after a period of 4 days or 5 days or a week or however long, we're discharging the patient. And they could go over to our transitionary care. It could be a health at home program. It could be a virtual care program, but we're discharging a patient. So all of the different elements of managing a hospital bed, we're doing that in the comfort of their homes.
Yeah, I mean, I've heard a lot of people call health at home by just doing everybody subacute, right? Less than ICU, but that's very fascinating. This question, and then that. Just take a second for it to come on, so you can just turn it on and then keep talking, it'll come on.
All right. Well, first off, congratulations, Rasu, on all the success of the hospital at home. Super exciting stuff. I'm a caregiver for my grandma, and she has to be admitted every now and then. And I'm sure we would love to have her be able to get the care she needs in the comfort of our home. So really hits home here. My question is a multi-part related to the technology required. So as this was a need that was emerging in COVID, what was the state of technology in helping facilitate the programs that you were, putting in place? And then what innovation have you seen along the way to further facilitate, and what are you most excited about in the future, whether that's AI based or not? Really curious.
Thank you for that question. So look, our core belief in continuing to push forward with the hospital at home and now the health at home program, because the hospital at home program is one element of it. It's the acute care elements that we have in hospital beds and ICUs and such. And to your earlier point, we're really growing this to chronically ill patients who get discharged from the hospitals, and we're now monitoring those patients, the congestive heart failure, COPD patients, right? We're monitoring those patients and making sure that they don't fall back into that circle of illness, that they retain themselves in that circle of wellness, all the way to the worried well, right? Folks like you and I and all of us in this room as well. So in that continuum, the technology really is different for different use cases across the board. The hospital home program that we had, we had, like I said earlier, some of the core elements of the virtual care programs, the remote patient monitoring capabilities and such as well. What we found was as we continued to scale this program across the greater Charlotte area, now really across Advocate, we needed to do this quickly. We know what we're good at, right? We're good at caring for our patients. We're good at really the care elements, the care team elements, really looking at these acutely ill conditions that need to be now innovatively cared for at home. And what we decided to do is we said, let's partner. Right? And we partnered with Best Buy Health. It was about 3 years ago is when we partnered with Best Buy Health. And as some of you might know, Best Buy Health is now actually coming into healthcare, right? So they're not just about selling flat screen TVs and Wi-Fi routers with the Geek Squad coming to your home. We are training the Geek Squad to become a health tech squad, right? So much like our paramedics that have been going to the home, we are training the Geek Squad to go in and look for fall risks. Look for, is there healthy food at home? Is there a fridge in the home? Is there a gun that is unlocked in the home? Is there domestic violence in the home? The social determinants of healthcare that really determine the 80% of the health outcomes. We are now head on going in and working with Best Buy Health to really take that into account as well. So the technology element continues to evolve. Remote patient monitoring is a no-brainer, right? So that is a requirement. The sensors and the types of sensors and devices, depending again on the acuity, the different conditions and cases. Now we're talking about clinical trials at home, right? And that's another different set of opportunities from a technology perspective. Imagine working with pharma, and we are working with J&J and Best Buy Health and Advocate Health in really looking at clinical trials at home, and that brings together different elements of technology as well. AI obviously factors into this. We are feverishly working together in creating what we're calling the Care Traffic Control Center. Right? As I painted the picture earlier of connected care everywhere, health systems really saying, all right, bricks and mortars will not go away, but care needs to happen everywhere. I believe that hospitals will really start becoming more like care traffic control centers. We'll have hospitals, continue to treat patients when they need care in the bricks and mortar facilities for OR procedures or scans or other things. But they'll also then become centers where we'll be monitoring the communities that the hospital is a part of and continuing to then look at that inflow and outflow of patients throughout that continuing care experience.
Yeah, what I love about the answer here is that they're not waiting to have every problem solved before taking care of the patient, right? Yeah. That's what other crazy people do is, we don't have this technology, we don't have that technology, so let's not do it. But we have to do the hard part to get the patient to experience what they care most about. And that's what I love about this is decision making. Go ahead, back there.
Thank you. I lost my mom in October last year, and she was hospitalized first time in her 85 years. And she had infection, sepsis, COVID on top of her, failing organs. So basically, when I heard you say ICU at home, it just hit home. I was like, I would love to have that available to me. And, I'm a proponent of it. Not going into hospital is one of the things that I always think about, having worked for hospitals for Bellevue for nothing. My question to you has to be a challenging one, so it can't be just an easy, softball. So what are your, I was going to say top 3, but top 2 resourcing issues? Because scheduled events, you can schedule them. get the patient or the resource to the house and deal with it. And the most emergencies, you can put them into the ambulance and send them back to where they need to. What is your middle ground, top two resourcing challenges for ICU at home?
Love
Yeah,
it.
yeah, it's a great question. Firstly, really sorry about your mom. I've got elderly parents that I'm caring for as well. My dad, Alzheimer's, dementia. We actually have him at home, and it's difficult. It really is. Part of the joy of working in innovative programs like this at Advocate Health is that these are deeply personal journeys for us, and we get to create impact, and we get to see this impact actually bear fruit. So appreciate the premise upon which you asked the question. There are a lot of challenges. For us, these challenges specifically around the hospital home program, also specific to the geographies that we're trying to turn these programs on in. So in the greater Charlotte area, it's a different environment than, say, the greater Chicago area, than, say, in Macon, Georgia, or Milwaukee, Wisconsin, right? So we're across the Southeast and the Midwest. The greater Charlotte area is one of the fastest growing areas in the country. Right? You've got 134 people moving into Charlotte every day. Right? You can't build hospitals fast enough. So even without CMS reimbursing or payers reimbursing for the programs, the truth of the matter, and don't tell this to the CMS folks, is that it made sense from an ROI perspective, right? Because we were able to capture these patients and treat these patients in these facilities that we were now growing as a result of the hospital home program. The challenge there was really looking at areas like the greater Chicago area where there isn't that much growth actually happening. And so for us, we really had to look at more of a capitated model in those geographies. And then similarly, when you're looking at areas like in Macon, Georgia, where we're also growing the program, the challenge also then becomes, all right, we don't have the mobile medicine programs as proliferated as we do, say, in the greater Charlotte area. So there are lots of challenges across the board, and that's part of the reason why we're partnering with a Best Buy Health, right? Best Buy has over 1,000 storefronts across the country. They've got multiple distribution centers and warehouses. So you think about these devices and the technologies and the questions you were asking earlier as well. They have the omni-channel elements, the warehousing elements, current
And the
health,
staffing that they can do.
and the staffing elements,
Yeah.
and the current health components of where the cleaning and the rekitting of if we were doing all of that. My team, working with the IT team, with the nursing team and others, were sitting down and rekitting these devices as we're discharging the patients and admitting newer patients into our facilities. So we had a lot of challenges in really scaling the program across the board, but we're now at a point where we've found our rhythm, right? We've found what we're good at doing and what our partners are good at doing. And we're at a point where we have an average daily census of 100 today. And we have signed off internally on an investment where we're 4xing the size of what is already the largest hospital home program in the next 2 years. So 2 years from now, it'll be 400 average daily census in our hospital home program, just in the greater Charlotte area. And we're also growing in like I said, everywhere from Macon, Georgia to Milwaukee, Wisconsin.
I love it. And so we're out of time, but I'm going to take moderator's prerogative and take a couple of extra minutes to let you talk a little bit about the workforce training, the next generation. So talk about the school. Where are you guys with that? Because it's one of the newest medical schools after Dell Medical School. So talk about that, and then we'll finish up.
Well, thank you for asking that question. I'll connect it to the Borderless hospital here with the adage that when we're training paramedics and others to go into again that sacred space that is your home and my home, it's important that they know what they're doing, right? So we're actually using VR headsets in our program that we're calling the Metaversity, to train these paramedics and others to really look out for X, Y, and Z, watch out for A, B, and C. And that's part of a broader program that we're calling the Metaversity. I was talking in the break earlier with Shahid that we are this year, this is a big year for us, 2025. So June of this year is when we're turning on our Pearl, the innovation district in Charlotte. Super excited about this. Once the innovation district is fully operational, it'll be 5,500 new jobs in the Pearl, 11,500 jobs as a result of the activities in the Pearl. So it's a $1.5 billion investment. Super excited about this. August of this year, we're turning on the new medical school. So Charlotte is the largest metropolitan city in North America to not have a 4-year medical school. So we committed to fix that, and we're fixing it. This will be the most innovative medical school in the country. We're flipping the curriculum. We're condensing what is traditionally a 4+ year curriculum into a 3-year curriculum, and in the additional year, really bringing in AI, design thinking, leadership attributes, and empathy-based learning modules. So it's really, really exciting where we are. We've got all the approvals and accreditations, and we're really looking forward to turning that on in August. And then in September, so it's a busy year. September, we go live with what we've been really positioning as the super magnet for the Pearl, our innovation district. And this is our experiential learning and surgical simulation robotics center called ERCAD North America. So ERCAD North America is a wholly owned subsidiary of Advocate Health, and it is a destination center for surgeons globally to come into Charlotte. And we're anticipating anywhere from 6,000 to 8,000 surgeons coming in every year to Charlotte to get trained on the latest of robotic surgery and minimally invasive surgery. So the way that we used to operate on our patients, just even up to a couple of years ago, was, dramatically big incisions. You're in the hospital, admitted for days at a time, maybe up to a week, exposed to nosocomial infections, hospital-acquired infections, and all of that. And today, it's 3 1-centimeter incisions, and you insert essentially chopsticks with AI and cameras, right? But we are needing to train the future workforce in all of this. So whether it's medical students, whether it's surgeons, whether it's paramedics, all the way to the connectivity that we're putting into our middle school and high schoolers, the HBCUs across the communities that we're a part of. We're excited about what we're doing through the Pearl, our innovation district, and continuing to innovate in the likes of the Borderless Hospital that we're talking about today, to other elements of care transformation, which really have to be more of this human-centered, person-centered approach that I was talking about.
Yeah,
today.
and what I love about this is that 10, 15 years ago, as you were starting at UPMC and doing the innovation there, it was more about mobile technology. And if AI was around there, what I loved about this conversation is it's all about the human doing the work, the patient receiving the work, and putting real money to educate that next generation. And that's really all we need here, right? Because if you can, because I'm not at all worried that we're not going to be able to build the tech. The tech is going to be there.
Yeah.
What to build, though? These students who are going through your classes
Absolutely.
should be saying, this is horrible,
Yeah.
or this is great,
Mhm.
right? And if you're offering tours and stuff, please let everybody know. I think we'll be happy to come down and take some tours. And you've got, of course, the Research Triangle Park down there. You probably have a lot of capabilities there. But I just enjoyed this conversation because whenever we talk, you're always doing 10 new things. So I just love that. So let's give Rasu a big round of applause.